All right. Hello, everyone. Thank you for joining us today. I'm Jeremiah Johnson. I am the Young Neurosurgeons Chair. I am joined by David Dornbos, who's going to be my co-host today, who is the Young Neurosurgeons Vice Chair. And we're going to have our 12th episode of the webinar named Women in Neurointerventional Surgery to highlight the incredible work and work that still can be done to promote women in neurointerventional surgery. So I want to thank our panelists, and we'll get to them in a little bit, as well as our guest speakers. And I appreciate everyone coming. We always like to kind of go over, for the uninitiated, what all this is for. So the goal of this webinar series is to provide students, residents, young neurosurgeons with timely information, education, and inspiration towards a career in neurosurgery. If you don't know what it is, the Young Neurosurgeons Committee is a committee of the AANS, which is the American Association of Neurological Surgeons. Our committee is committed to developing future leaders in neurosurgery and providing a channel for the young neurosurgeons group, which is generally considered to be medical students interested in neurosurgery, residents, as well as young neurosurgeons within about 5 years of finishing their training, and allowing that group to have a voice in organized neurosurgery to impact the direction of the field. What is the AANS, you may ask? It is as I alluded to earlier, the American Association of Neurological Surgeons. It's a scientific and educational association of more than 10,000 members worldwide. And the goal of the organization is to guide the field of neurosurgery, and other roles, important roles include education, advocacy at the national and local levels, promoting highest quality patient care. So then what is NREF? This is an NREF Young Neurosurgeons webinar. So NREF is a non-for-profit 501c3 organization created by the American Association of Neurological Surgeons with the goal to support basic science, clinical research, as well as lifelong education to foster improved outcomes for our patients with neurological diseases. They do a tremendous amount of work funding research by young neurosurgeons, as well as education of young neurosurgeons through courses, and we very much appreciate their support. Today, myself and Dr. Dornbos are the co-hosts. You've watched these webinars before, you probably know us. I'm an assistant professor of cerebrovascular and endovascular neurosurgery at Baylor. I'm the chair. Dr. Dornbos is the cerebrovascular and endovascular fellow at Sims Murphy Clinic in Memphis. So welcome to David and myself. This is a unique webinar in that it's co-sponsored, not only with young neurosurgeons as well as NREF, but also the AANS CNS joint section of cerebrovascular, and Young NIR, which is a group of young neurointerventional radiology and neurosurgeons and neurologists who are here co-sponsoring this talk today. From there, I'm going to hand it over to David to introduce everything, the speakers and the panelists. This is our 12th episode, as I said. Please follow us on social media, and we'll give the social media handles for Young NIR as well as CV section in a little bit. Then you can hear about future episodes. All right, David.
Awesome. All right, thanks, Jeremiah. Thanks, everybody who was able to make it. We have a great group of both speakers and panelists as well. Just to introduce our panelists off the bat, Dr. Mcgarris, the current chief resident and soon to be vascular fellow at University of Illinois Chicago, is with us. Dr. Zachary, who is currently a resident at The Ohio State University in Columbus, and is going into vascular in the very near future. And also Dr. Kim, resident from Loyola, who, from what I understand, is still planning on going into tumor and oncology. However, hopefully we can sway her today. But this was kind of her brainchild to kind of put together a group of well-known women at the top of our neurovascular field, just to kind of get their 2 cents on kind of their background, their upbringing, and where they're at today and where they hope to see the field go from here. Go to the next slide. For our featured guests, we've got 3 excellent speakers and neurointerventionalists and neurosurgeons in the group today. Dr. Inoa, who is currently with me here at Sims Murphy in Memphis, Tennessee. Just for some background on her, she did her neurology residency at the University of Connecticut before moving to Beth Israel for her vascular neurology fellowship. Ultimately came back to Connecticut for her INR fellowship before coming down to Memphis, Sims Murphy Clinic. She currently is on the SNIS Foundation Board of Directors. She also is on the leadership committee for MT 2020. She's actually the co-chair for MT 2020, which is run through SVIN. And then next, Dr. Jim Mcgarris is currently next slide, a full professor at Thomas Jefferson. She did her residency there and her fellowship there before staying on as faculty, and has really been quite prolific from a publication and organized neurosurgery standpoint. She's currently the director of the Open and Endovascular Cerebrovascular Fellowship there, and is the associate program director as well for the residency. She's the current secretary of the Joint CV section and was the first female dual trained neurosurgeon in the United States. And then last but certainly not least is Dr. Tsai. She did her neurology residency at the University of Toronto before going out to the West Coast to Stanford for her vascular neurology fellowship. Ultimately went to Cleveland Clinic for her INR fellowship and is now an assistant professor at Michigan State working with Spectrum Health. She's currently the chair of the SNIS Young Professionals Committee, is a member of the SNIS Board of Directors, and works as the clinical trials oversight officer at Spectrum Health. So from that, I would like to turn it over. Why don't we start off? I'm not quite sure if Dr. Noah has made it yet. Let's start off with Dr. Jim Mcgarris, if you don't mind kicking us off.
No, not at all. So I want to thank the committee, Dave, Jeremiah, and our panelists for the invitation. Can you guys see my screen?
Yep, perfect.
Okay, great. So some of the topics we're going to talk about, I'm going to cover the increasing percentage of female medical students across the country, and provide an overview of how we advise medical students and residents that especially consider open vascular and cerebrovascular fellowships in a career. And then lastly, pearls and pitfalls for students or residents that consider this as a career choice. Talking about our own medical school here at Thomas Jefferson, which is one of the oldest medical schools in the country, although we were established in 1824, just about a little less than 10 years ago, we just celebrated 50 years of celebrating women in the medical school, which is pretty remarkable how short the interval is. Considering that the first female physician was Elizabeth Blackwell in 1847. She was British born, and she was the first to reach an MD. So 1961 is the first time where a woman was admitted in the medical school, and we've come a long way. Made up for it in 1981. We actually honored the first female dean in our medical school. And these are some of the achievements of women in medicine. Some noteworthy ones are in 1998 was the first year where we had over 50% women in the medical college. And in 2002, we have the first chair in both clinical and basic science departments that are women. This was just published in the Washington Post, data from the AANS for 2019. And out of nearly 50,000 medical students, for the first time in the country, a greater proportion were women at a rate of 50.5%. So this is just now starting to create equality in the medical schools in terms of admission of medical students. What is some of the advice for female medical students and residents that are pursuing vascular as a career? I don't like to separate cerebrovascular and endovascular, especially these days. I think within the neurosurgery field, the two are really, really intimately linked. And you need to be able to be dual trained if you're going to be up to date with the latest technology. So some key components of a successful career is an early mentorship in your career. you need to reach out and establish role models. And some of your role models may be women, some of the role models may be men. You just need to make sure they have your best at heart, and they will guide you and coach you along the way. Ensure a passion in the field. I feel like almost every emergency and neuroscience tends to be vascular, especially 3 o'clock in the morning. We all know acute ischemic stroke has really been a game changer in terms of lifestyle. It really increased the number of cases you may be doing, unfortunately, in the middle of the night. So make sure that you take a lot of call and make sure you enjoy this kind of lifestyle, which could be yours. Let life happen. A very common question, especially women that are pursuing this, is what were the hardships in trying to find a spouse, trying to get married, when to have kids? And in all honesty, you just can't predict that. So if it's the right timing for you and you happen to meet, your special one, I wouldn't delay starting your non-professional life because life just happens and you just need to figure it out and you just need to keep on moving, which is what we all have done. And there's never a perfect time. When is the perfect time to have a baby for males and females? But, for females it's a little more complicated because you have to bear the child for 9 months. There's never a perfect time. When you're a medical student, well, let me get my diploma. When you're a resident, okay, let me finish my residency. And then, well, I want to do fellowship. Then you're a young attending, I want to establish my practice. And then you're an established attending, well, you have all these meetings and all these. So there's never a perfect time. So just keep on going and make your family and build your family if that's what you wish. And don't consider where you are in your career because it will never be perfect. I always advise females in medicine to build a support group at home, especially once the kids are coming into play, because it's going to be really tough sometimes to juggle everything, call and professional life and a family life. So that can mean you have parents helping you out, you have friends that you carpool with, you have live-in nannies or live-in mommies, such as myself. Any way that you can make it work, just have that support group that at any given time you can fall back to into your personal life. You need to also find the right place. So when you're in medical school, you need to find the right residency and the right hospital that will encourage women and physician families, what we used to call a female-friendly program back in the day. I want to think that in these days, there shouldn't be such a program, and all programs are like that. Nevertheless, this is when you're visiting your potential universities for residency or for fellowship or eventually to sign on as staff, make sure you relate to your teammates, you relate to your residents, your co-residents. You have a pretty comparable distribution and you have enough representation of women in the program. And as an attending, when you're a resident, that you can relate to your other, especially junior attendings, that they're happily married with families, and you can socialize and relate to that environment, because again, this will be your home away from home. So just be very careful in your selection process. Some pearls and pitfalls. Learn how to say no to some extra tasks that you may not need. I may be preaching to the choir, but automatically saying yes to every little thing you're invited to, perhaps early in your career, it's hard to resist, but as you're maturing, both as a medical student, as a resident, and just learn which ones, depending on your efficiency, which ones you're able to accomplish, and which ones, you should probably just say, thank you for the invitation, but I cannot do it. And that can be a tough balance that you will juggle with, especially in the beginning of your careers and every step of the way. I think this past year has really been remarkable in terms of teaching us how much you can accomplish at home and how you could potentially be with friends and your family at home and leaving your office when the work is done. When I was a junior attending, I used to think, well, if I finish my surgeries at 2, I have to stay there at least until 6 because I'm a neurosurgeon. I need to work until 6 o'clock. And then if you're on call and you get to 3 o'clock in the morning, double cases, then you regret that. And you said, I wish I left when I had the chance. So you can accomplish a lot from home. If you're efficient, you can do research at home, you can publish from home. So any chance you have to leave work, take it. Don't feel like you have to stay in your office and, to show that you're a good sport. Combining work with family travel. This is wishful thinking. I'm hoping pretty soon all these meetings will be actually in person and not via Zoom. It's always a good option to try to incorporate a small trip if you're busy and traveling and giving lectures. When it comes to the actual training, I think a common question is how to handle, if you're a woman in the field, the surgery humor. And it's a little bit of a tough question to answer because it depends on what kind of humor we're talking about. If it's a benign comment that you think is not really offensive, but a little bit off what's accepted, I would stand up, let somebody know that, hey, I didn't appreciate that. And you don't have to be mean or nasty about it. But I think standing up and letting a colleague know, even if it's one of your own friends, that, what you just said that's not cool. I don't appreciate it, and it just makes me feel uncomfortable. It's very important to just completely eliminate that old school, we call it surgery humor, but potentially it could be any kind of medical humor that is not inclusive to gender. Of course, there's different levels and different tiers of that. If a comment or a statement is completely offensive, then you need to take it to a whole other level. And I believe in any university, there's anonymous or eponymous lines where you can actually file a complaint. So there should be zero tolerance for any of such comments. And especially with vascular, at any given point, you could have 10 to 15 patients in the hospital, some of whom may not be doing so well. You're going to be handling a lot of critical patients, and some of them will not make it statistically. You need, as best as you can, to leave your work outside your home, at your doorstep, and not bring it in, because you're going to struggle in the beginning, and you're going to worry about your patients, and you're going to have a hard time also worrying about your kids and worrying about something at home. So when you're not on call, try not to be on call. Try not to bring everything at home, and have your partner who's on call or whatnot manage, and don't bring all that stress and anxiety as best as you can to your doorstep. And, we're focusing on how to get through this, and how to apply for the best residency, and how to get into the best fellowship, and how to get all these publications. And before you know it, you're, 15 years out of residency, and life is happening. So as much as you can, try to enjoy it and try to have fun. And, hopefully you'll build lifelong relationships with your colleagues and your coworkers, and friendships that you'll cherish for life. This is a great venue, and I know all of us here on the panel, the speakers, are available to give advice regardless of where you're located in the country, and we hope to see you succeed. So I'll end with that. I think there's going to be a lot more Q&A in the end, and I'm happy to answer any more questions. Thanks again.
Perfect. So we'll start with a bit of a historical perspective on kind of where things were. And this is a paper that's essentially revived by JAMA back in 2020. And the first publication was back in 1945. And this is really just to show how far we've come. Back then, they were talking about questioning the effectiveness of women as physicians. And at that point, the question is, should we remove that glass ceiling of 5% of the total enrollment to allow it to be 20%? And the interesting part, I think, as well, is that this is a paper written by two non-medical scientists to encourage a consideration for increased enrollment into medical school for women. And there were a lot of gender bias comments or justifications, so-called justifications that were given at the time, where people are talking about families and women dropping out. And I think that's left a very long legacy of what we're seeing as some of the gender disparities, even stretching into today. So things have changed, and it's important to know that we're driving this change because we're not so much asking for things to be better for women. We're asking for equality, where equality is there in the workplace, equality is there in professional development, and we want merit to be the forefront. We want to stop thinking about gender at one point in the path of this profession's growth. And we know that bias is often subconscious. We want to have an open discussion. So panels like these, webinars like these are so important to drive that discussion and lead to purposeful change. Okay, to advance my slides. All right, so this list comes from a paper by Stevens and others published in JAMA Surgery last year. And you can see that when we think about the negative impacts that are related to a gender bias, there is a long list of things that can hurt us. Some of these are very difficult to measure. Gender bias, harassment, and discrimination. How do we measure that? It is self-reported. What we do know is those numbers do vary. It goes from 50 to up to 65, 70%, but consistently over 50%. Over a third of women will report that this is a barrier in their medical professional development. So that's a very important thing to keep in mind. As you go through this list, things like abuse and harassment, underappreciation, sometimes inappropriate advances, we're seeing those things come from a much larger scale than perhaps just our colleagues. There is a mentorship difference. There is a difference in the way we're treated by the administration. There's a difference in the way we're treated by our patients and families. And in fact, patients and families will account for over 20% of what women are experiencing as disparity in the way we're treated in the workplace. So that's an important thing to keep in mind, that there's a broader social context in which all of this is occurring. I'm going to jump a little bit down the list here. And when we talk about integration of personal and professional lives, you heard Dr. Tjoumakaris say, we really have to take lives as they happen, right? This is really important. But when we think about the things that are unique to women, things about carrying a baby, perhaps, maternity leave is often given as the 4 weeks vacation plus 2 weeks of so-called medical condition time. In some ways, that's discriminatory, right? Because there's no male equivalent, so that becomes a female-only issue. What about men who want to take paternity leave? Those are all questions that are very relevant to this gender discussion. And as I was going through the literature to try to find, how do we better define these discrepancies that we're seeing? How do we make these changes? I came across a number that was starkly worrisome. And that is the suicide mortality ratio that was published in the paper in Psychiatry last year, where if you look at women who were working in medicine up until 1980, the suicide mortality ratio is somewhere around 2.20, 2.27, 2.3. That same number is 1.4 for men. Both have improved since then, but that big gap between men and women still persists. And that, in many ways, is to show how much we are internalizing, how much we're bearing as women in these fields. And it's important that we address those things because we need to close that gap. And what is also really important is the research and funding aspect. There is a gender disparity in H index across all fields in medicine. And that brings to mind the late Dr. Mcgarris, who I had the pleasure to know when I was doing my stroke fellowship at Stanford. So Dr. Mcgarris' story is that, well, Dr. Mcgarris started as Barbara, not Ben. And when Barbara was at MIT, she was outstanding. She quickly became the guru of glial cells. And for that, she was recruited to Stanford University as a professor. During those years, Barbara transitioned to become Ben. And as Dr. Mcgarris would later tell me, the world likes Ben better than Barbara. Ben had more funding, Ben had more grants, Ben had more publications. And of all things that were just absolutely stunning that Dr. Mcgarris will always talk about is that people now let him talk. People are paying attention. And we should pay attention. When in forums where there are men and women, we need to pay attention to what the women are saying. We need to pay attention to those times when people are letting the women talk. And that is, you know, part of those small details of what we live through potentially as gender disparity that can escape people's attention subconsciously for the most part. Now, Dr. Mcgarris also said something that's very important for us to remember, which is don't stop fighting. That equality will come, but we can't stop fighting. And things are changing. This number is just so important and so pleasing for people like myself who just love to see women thrive in our fields. And Dr. Tjoumakaris said the same. It's since 2019, over 50% of medical students in the U.S. are female. However, women account for about a little over 34% of active physicians. We're currently practicing, and this is medical and surgical. Here you see some numbers that are more relevant to neurosurgery. By over, well, it's still a very small number. We're seeing 172 American female neurosurgeons, and only a little over 10% of them are in academic medicine. And that number is also very low as we look at the number of women who are able to climb the ladder in terms of their seniority and their recognized leadership roles in their respective institutions. So, you know, this is very important for us to bear in mind as we're moving through the next few years, and these discussions are so open to try to improve women's role in medicine and surgery. There's also an element here that I think multiple societies are really actively addressing, and that's the fact that there is underrepresentation of women as authors on editorial boards, as moderators, and as speakers at conferences. And those things hopefully will see really significant changes now and over the next many years. Why do we want diversity? Well, diversity matters because in many systems, politics, bioeconomics, we are seeing that diversity improves the system, make us more productive, and when things go badly, it actually increases resilience because that diversity is able to absorb some of these negative changes. There are some literature, you know, out there about what women really bring to care as being potentially better. Some of these studies really look at whether there's better outcomes, but across all these measures, I think what really does transpire is that women provide care that is not inferior. And if there's some areas that are better, it is not there to show that women are better physicians or better surgeons than men. It is to show that together we can move the field forward and we can do better together, and therefore that equality is important. So I'm a guest member on the board of the Society of Neurointerventional Surgery. So these are numbers that are easy for me to, well, I should say easier for me to ask the staff to share with us. But again, you know, not all neurointerventionalists are part of the same society. So this is just to give a flavor here. We can see that the senior members, those are currently in practice, there's only 7% female. Among the junior members, the number is encouragingly close to double of what we have. So things are changing and things are evolving. And of particular attention, but we are starting to drive the attention towards all these elements that we're discussing tonight. The Women in Neurointerventions is a group that is present across multiple countries and multiple societies, and it has basically gathered a lot more attention. So this past year at the annual meeting, that particular session for Women in Neurointerventions gathered a whopping 217 attendees, including both men and women. So that is really, really important for us to know. And when we look at the role of women in these neurointerventional societies, the other thing that we also want to look at is the role of women in leadership positions. So the SNIS started as the ASIPN, and back in those days, you know, this is a very, very small field. It has rapidly grown. It has basically had multiple generations of board of directors, and across all these years, myself included, there has been 4 female members. 1 past president who's a woman, and then 3 in voting and non-voting positions, including myself. and of all of us, actually, there's a person that also stands out, not included in the four of us, and that is our executive director, Marie Williams. She is not a physician, but she has been there through all these generations of leaders. And I wanted to bring that up as an important point because we think about women in neurointerventions, we think about women in neurosurgery, but there's a broader context here, and it's important to pull in all the allies that we've got. One more thing I want to mention about kind of where our role is in neurointerventional surgery, and that's something that is certainly present across surgery in general, as well as the neurointerventions. And that is kind of what our relationship is with the industry as well. I have two male partners. The relationships that we have with our industry reps are different. The way we talk to them, the way they interact with us, unfortunately, it's different. And I have to say they're not always pleasantly different, but there is definitely a perceptible gap there that I hope over the next few years we're going to see a little bit more closure. Now, to belabor this list, there's many efforts being made to increase support for women in leadership positions. And this is a very exciting time in that sense because we are going to see a lot of changes. I will draw your attention to the mentorship program. That is a formalized effort that I think the SNIS has really made it and pushed through. And that is to allow younger women in these with vascular and endovascular interests to find women mentors who may not be, geographically close to them, and to encourage role modeling even across the distances. And just like Dr. Tjoumakaris has mentioned, it's very important for us to recognize that our mentors and our allies can be male. I had very few female mentors as I decided to follow this path, and you get to a point where you feel like you don't know where you're going next. And that's where your male mentors really step in, and they can really help you along. And for those of us who are men present tonight, that's also something that we would appreciate, and we certainly do appreciate seeing that you're on this webinar, that you are really listening to the issues that we're facing and helping us along. Ultimately, the women's issue is not only relevant to women, it is relevant to everybody. Men are allowed to spend time and want to spend time with their children. Men are allowed to want to have paternity leave. I was recently asked if we were going to hire on somebody who is imminently going to be taking paternity leave. And I think that's an important perception bias we need to start coming across, that men are allowed to be parents, just like women are allowed to be surgeons. And the real big issue here is that we're talking about gender disparity, but there's a bigger context always. And racial diversity, ethnic diversity, ability diversity, these are all things that need to be discussed as well. So we're barely touching the tip of the iceberg. But the very new efforts to formalize diversity committees and task forces will start changing how we view ourselves and our colleagues as a profession. So I'm going to wrap up here and say that, at the end of the day, to recognize that there is a disparity is going to be the first step in improving where we are. And in the ideal world, we are going to get to a place where gender is no longer an issue. It will carry no weight against merit as a way to move individuals forward in the field, in the profession. And this is going to be a collective effort. So just to close, these are two pictures from a particularly busy weekend, where you can see my neurointerventional team of technologists and nurses on the left, and on the right was our neurosurgery team, including in the right lower corner here is Dr. Rashna Ali, my functional neurosurgery partner. And these are three of our APPs. 75% of our neurosurgery APPs are female. So that was an all-women weekend, and we can definitely see how the workforce is changing from several decades ago. So thank you very much. That's all I've got.
Yeah, I'll jump in. I have a question that I think might be useful to some of the audience members, because I was looking through the list of the participants and I recognized a few of the names of some of the medical students that I've worked with And I think it would be really helpful if either of you could comment on what's it like a day in the life as a woman in neurointerventional practice. What types of things do you see? Just what does your day look like on a day-to-day basis?
Hi, I can start. So from a neurosurgery standpoint, the day can start, let's take a day where I'm not on call. I would typically, so I'm married, both myself and my spouse are surgeons. My husband is a hand surgeon and we have 2 kids. And we juggle throughout the day. We have a live-in nanny, and even still, the 3 of us are in a constant juggle. But any day, I've shifted my practice a little bit. Typically, the day starts, I arrive in the hospital probably between 6:15 and 6:30. You see your pre-op patients, and then you round on your existing patients. We have a great team at Jefferson. We actually have 3 neurointerventional and cerebrovascular fellows, so they're joint fellows. 2 of whom are women, and actually both of them are staying on board as staff. Sana Theophanis is Jefferson trained, and Victoria Schuneman is trained in Ohio State. And then we start tackling cases, and it depends on the case. On a day where, you know, we could have, and this is just my own practice, it could be, you know, 4 to 6 cases, sometimes 10 in the interventional suite, and at times it can be an open case, like an aneurysm clip. And depending on the day, your day can finish surgery-wise anywhere between as early as noon to as late as sometimes 5 or 6 o'clock. So you want all your patients to awaken and do well, and then you'll do your evening rounds where you have to see your post-operative patients, make sure they're as well as your residents advertise, and then off you go. And then depending on the time of the day, you try to pick up the kids from school. And I have to tell you, there's no greater joy than seeing the faces of my kids at the carpool line when they realize that it's mommy or daddy picking them up, as opposed to our lovely nanny, without whom we couldn't function currently. And then once you go home and you really have to just, like I said, leave the work behind and just stay on the kids and, you know, your spouse. So, you know, enjoying dinner and trying to prepare things together. And, you know, we actually have a little routine where we go around the table and ask each other, how was your day, and what was good about your day, and what was bad about your day. And it's surprising how many times my kids will say, well, the best part of their day was mommy dropping them off or mommy picking them up. So it's paramount to try to spend as much time as you can and try to balance work life with the family. And then, of course, I bed very early, especially if I'm on call. I can be in bed as early as 9 o'clock. So if I doze off in half an hour, don't mind me. And back again at 6.
Well, we run virtually for the most part nowadays here in Grand Rapids, and so first thing in the morning, you're kind of, you know, battling teams and getting on the virtual meeting, which usually is before I really step out of the house most days, unless I'm on call and you know, I'm already in the hospital. And I don't have children. I'm not married. I live with my sister, who's my closest family member, and we have a young dog. Now this dog is getting way too much attention, so I'm doing the dog mom thing where I have to drop off the dog at daycare and then rush back to work. And then it depends a little bit. Being an interventional neurologist, there are days where I am in clinic. There are days where I am on the stroke service, and there are days where I am in NGO doing cases. So what really dictates how our lives go is really the call schedule. I am one of a group of 3, so we're on primary call 1 day out of 3, 1 day out of 3 we are on backup call, and that essentially means if any of my partners is on call, but in the operating room, I get the case. So you can start out a day very peacefully, thinking you're going to follow your schedule, and the next thing you know, you're 3 more cases in, and there's a patient comes in with hemorrhage, and you need to deal with that immediately. So life gets pretty exciting, and the interruptions, unfortunately, when you're a vascular person, are what makes you really happy. It can make your day go really long, but this is the part where it's important to like your job. So I wrap up whatever I have to wrap up, and usually at the end of the day, I'm darting out of there to try to make it before doggy daycare closes. And I think, the family component is so important. I come home to my family, and the important thing that we always do is to keep about 2 hours at night where we're just basically spending time with the family, sometimes calling up other family members or friends, and really just shut down, the work brain for a little bit if you're not on call, and enjoy a little bit of balance in this whole equation.
So Jenny and I don't want to scare you, but probably at least once or twice per week, the weeks you're on call, while you're in bed, you will get startled still by the call at 2 o'clock in the morning of an M1 occlusion who's a good 89-year-old. And that's when the passion for the field will kick in, and the adrenaline rush, and you just get up and you drive like it's 3 o'clock in the afternoon. So don't forget that.
Let me keep going here. Thank you, everyone. I'm happy to be here. Violiza, Inoa, and with Tim Murphy Clinic. So I was asked to talk about radiation exposure and impact of pregnancy and family on decision making. And I was also asked to give some of my personal advice. Unfortunately, it's going to be redundant. I think Stav and Jenny covered part of it, but I think it's going to bring up a few interesting discussions here. So about radiation, I think by far one of the most feared issues, situations in neurointervention is, occupational radiation exposure. And it's not only females. I think men also fear about radiation. We know that radiation exposure can be detrimental for you, and if you're a female and you're pregnant, it can bring up teratogenicity. There are 2 types of effects for radiation exposure: deterministic and stochastic, if you remember. So the deterministic ones are the ones that are directly related to radiation exposure. And some of the effects that we can see in the fetus will be growth retardation, low IQ, mental retardation, pregnancy loss for the female mom, etc. So for a stochastic radiation, those are the ones that occur by chance. Those are called random. And although they do not have a threshold level of dose to cause any harm, the probability is still proportional to the dose that the mom is exposed to and the fetus is exposed to. So what we know is that radiation exposure is going to depend on, or radiation harm is going to depend on the amount of radiation that you get, and also on the age of the fetus. We know that the first trimester is going to be more harmful with greater risk for radiation side effects. So there are guidelines on this. They do not come from neurointervention. The NCRP, which is the National Council for Radiation Protection, states that the fetal limit should not be more than 50 milligrams per month. And I'm going to give you perspective because I'm going to show you my radiation exposure when I was pregnant recently. So what they say is that if you're less than 50 per month or 500 milligrams throughout your pregnancy, the effects of radiation on your fetus should be negligible. And same with the obstetric committee, they recommend a low dose. Of course, they said that the risk of miscarriage, malignancy, malformation is going to be pretty close to zero if you go below the standard recommendation, and they brought up the number of 5,000 milligrams. So that's still way lower than what the NCRP is recommending on their guidelines. So again, most of the data comes from other specialties. Radiology is up there, cardiology is up there, and they actually have a document that they released on what is the radiation exposure to the pregnant cardiologist. And it's interesting because they said, well, concerns over radiation exposure should not be a barrier to choice in pursuing a career. And I think we know that that's easier said than done because I'm a female, I've been pregnant, and I mean, that was the first thing that I thought about when I became pregnant. I was like, oh my goodness, what am I going to do? And that's when you have to recur to the data that exists, but also you have to call your partners, your mentors, your female friends who have been pregnant and have been doing neurointervention and have gone through same experiences. So I think, part of this, community partnership is important because of things like this. The support system, I think, is really helpful. So when I looked into data about radiation exposure specific for neurointervention, I essentially didn't find anything. And there was a nice study that many of you know by now. It was published by Stephanie Chen and Mary Christine Brunette, fellows at Jackson Memorial in the University of Miami. And this was a retrospective study, but it was so meaningful and impactful because they were able to demonstrate that a woman practicing neurointervention and protecting herself from and her fetus from radiation exposure actually had a great outcome in terms of the total radiation amount that fetus was exposed to. So they used 2 fetal monitors, and a fetal monitor is essentially a dosimeter that you place underneath your lead apron. So they used 2 of them, and they measured radiation on the mom and on the fetus. And they realized that although the mom had been exposed to the same amount of radiation throughout her pregnancy and before her pregnancy, the fetus, the dose to the fetus was essentially negligible, was 0. And I think, this is first of a kind. We didn't have this data before. And Zoom is asking me to join audio now. That's fun. So I think, and again, this is very important. And my experience is in this table right here. So I was pregnant towards the end of 2019 and the beginning of 2020. And if you can see here, that N means nothing, 0, minimal. So of course, I am in a practice where I have a lot of support, a lot of partners, great fellows who are very independent. And, I was protecting myself and being very cautious about, protecting my fetus from radiation. But overall, my radiation exposure was close to 0 as well. So I know that personal experiences and retrospective studies might not be enough. We are actually working on this, and both the staff and Jenny are helping me in coming up with a study, and I'll let you know in a bit about it. I thought that was going to be my next slide, but I think the important point about this slide is that we are not implying that you should not be careful about radiation and fetal exposure to radiation. I mean, I think the potential damages are real. There's real teratogenicity with exposure. However, there are certain principles that we believe that you should strongly follow. You have to protect yourself and your fetus, and the radiation should always be minimized in order to avoid those teratogenic effects. So the things that we do, the things that are recommended out there, and you can find it in any of these guidelines, are obviously follow the ALARA principles. So minimize the radiation exposure to, you know, the most that you can, consider extra shields, know the floral techniques. So we have to be conscious about the duration of the procedure, the scatter radiation, how to avoid that, shield yourself. You know, sometimes people do I used 2 layers at the beginning of my pregnancy. That is not necessarily recommended. Some people use maternal lead aprons as well. The fetal is very important. I know that some people are shy about saying that they became pregnant, but I would suggest that you go to your radiation safety officer right away. So obviously you have the right to disclose your pregnancy status at any point during your pregnancy. But I think, you know, for your safety and the safety of your child, it would be good for you to inform that to the right people. What it is recommended is that we wear at least a 0.5 millimeter thickness of lead apron across your belly, your abdomen. Most people use 1 millimeter, and as I said, you know, double layers or extra protection, you know, is often used by many people. So this is the study I was talking about. It is the expectant study. It is about measuring the total radiation exposure to a fetus in neurointerventional procedures. So both men and women will be participating in the study, and we're going to ask the participants to wear a fetal dosimeter underneath the lead apron, and we're going to measure the radiation exposure to the fetus over 3 months. And I'm excited about this. You know, it has been funded already. We submitted the study and the design to the IRB, and it's in the final stages to being initiated. So hopefully by the end of the year, we will have more information on this. So when we talk about the decision-making process, I truly believe that neurovascular, like Stav was saying, intervention, neurosurgery, you know, choosing a career that is heavy loaded in terms of work, that is busy, that is very demanding, truly affects one's decision-making process. And we see this in the numbers, you know, in the objectives. When we know that more than 50% of the medical students are females, and still we see this preponderance of, you know, females to choose fields over others, you know, being neurointervention and neurosurgery, some of the most male dominated. We know that, I mean, these things affect your decision making and your process, right? So we have asked medical students multiple times. There are surveys. JAMA has a very nice one, and surprisingly, although people go into medical school and they know they're going to work hard, at the end of the day, when they have to decide about the rest of their lives and their subspecialties, work-family balance and lifestyle are up there. People talk about it all the time. That is important in order for you to make a decision, and it should be, right? For neurointervention and for interventional specialties, women are very open about, you know, radiation exposure. We talked about it, and also the lifestyle and the long, extensive procedures, and people fear about those. I think part of the reason for this male predomination is that we women, as you know, as primary caregivers for our families, we feel that, you know, a career that is so loaded is not going to be compatible with a healthy lifestyle. And I mean, I have to say that is not my opinion. I know great women in the field. I see 2 women here that are sharing this webinar with me, and I can tell you for a fact that, you know, you can still have a balanced, happy lifestyle and do something you love. I came across this paper recently, and I think it's so important, and all of us should read it if we're interested in a career like this and neurosurgery. So this is based on a survey released by the Society of British Neurological Surgeons and Neurological Trainees, and they gathered more than 300 neurosurgeons. And although the rate of or I would say the women in neurosurgery, I think they have only 8% of women in the field. They were able to capture 91 of those women, and those women actually filled the survey. And the responses were very interesting. I'm not gonna quote the entire study. I'm going to focus on things that have to do with lifestyle. So they found that if you're a woman in your surgery, you are less likely to be married. You are more likely to be single. You're less likely to have or want a child. And they found that 13% of the women would defer the primary care of their babies and children to their significant other versus many men, which is not surprising, right? Because I think, again, as women, we feel that we have to be that primary caregiver. We have to take care of that household. I'm telling you, because especially from my background, I'm Hispanic. Oh my goodness. I mean, that was what I learned. Like, it doesn't matter what you do. It doesn't matter how busy you are in your career. You still have to be that primary caregiver, and, you know, house needs to be pretty, and dinner needs to be served. So those are the pressures that, you know, that we have as women. And definitely, you know, that is gender related. One thing that I found interesting is that 35% of the women said that they were able to share their career, and they were still able to be the primary caregiver of their children, and that was only the 1% for men. So they asked open questions and they had comments, and one of the common ones was that women felt that they were discriminated against when they asked for family time, when they took time off for maternity leave, and etc. So another interesting fact, when they asked about gender disparity in neurosurgery, most women felt that if it was a true issue, more than 50%, like we see here. Only 29% of the guys actually thought that there was some gender disparity in the field, and I think part of it is because of, you know, our small unconscious actions that we don't recognize, but women and people that might feel a stereotype recognize right away. And I think we all should be cautious about that. You know, like Jenny was saying, things we say, actions, how we treat people and how other people treat us. And I mean, those are like the subtle messages that happen at work, those subtle conversations that, you know, people who are, again, more susceptible for discrimination or being a stereotype, like, get, you know, it's not that subtle for some people, right? So I agree that doing things like this, you know, creating awareness, talking about it, you know, putting a light on, you know, women or minorities, I think this is great, and this is work that needs to continue to be done. There's a lot of awareness, a lot of media involvement. I received an article from one of our friends, who one of my colleagues from work, and he, you know, sent me this article that you see here. It was a publication, first page on Yahoo Finance about, you know, sexism in medicine, and they had few women in the article. You can find it. I think it's very interesting, and one of them is a woman who's a minority, who's a leader in neurosurgery, and I think, you know, her words were very on point, and there was a lot of wisdom there. The Society of Neurointerventional Surgery will be releasing a survey within the next couple of weeks. We have worked on that. Jenny has participated on that, and it's about diversity in the neurointerventional field. We talked about women in neurointervention. Those are meetings that are happening. I think it's great to meet other women in the field. This is also a flyer from SVIN that I saw recently. So, and this is all happening recently, not necessarily as part of this webinar. It's just, you know, independent forces are unifying and we're spreading this voice, and I think that's extremely important. So when I was asked about advice, I guess it's difficult because obviously we have different backgrounds and the situations are different, but, you know, few of the things that I thought that maybe we could generalize a little bit include, you know, make your decisions based on your goals and priorities. Do not overthink that you're a woman or that you're a minority or, you know, that your primary language is another, you know, just work hard towards your goals, but do not think about, you know, what you think might be limitations, because they're not. So we all know that talent and hard work comes from in different shapes and backgrounds and genders. So I think, you know, we should be thinking about that. Be outspoken. Personally, I was very shy about saying I wanted to become a neurointerventionalist. I think part of it was because I thought it was too competitive and people would see me as overambitious. And I regret it looking back, because once I said it, people were extremely supportive and things happened. I thought having your family and your close and your close friends supporting you was going to be enough. I think that's absolutely crucial, that you have a plan. You know, if you are married, if you have a significant other, say, listen, you know, this is intense. This is going to be a busy path. So this is what I want to do. Are you on me with that? And I bet, you know, you're going to have a very positive conversation when you lay the plan of the ground, or however you said that initially. So individualize the process. You're meeting people here, you're hearing about your experiences, but that's not necessarily you. You have a different personality, you have a different background. That doesn't mean that you're not going to make it. Just again, it's going to be you. So establish and respect your boundaries was going to be my next one. So as women, we feel that, or minorities, I must say, one feels that we have to overdo it. You have to compensate. You have to try to be the best of the best, because otherwise people would not respect you. And goes back to what Stas was saying, you don't want to say no to opportunities. You want to be an overachiever. And in fact, if you carry that on, you're going to be exhausted and overworked. So at some point you need to stop and say, you know, this is what I want, but also I have a family, I have my boundaries, and you need to respect that. You need to get space for yourself. And lastly, I want to say that mentorship, like Jenny and Stav were saying, is crucial. So getting those champions, either females, males, people that support you, that trust you, and that, you know, walk along with you, that's extremely important. And not for you as a female necessarily, but just for you as a person. So establishing your role models since the beginning is very, very important. And I think if you find people that you admire, but also that live a lifestyle that you agree with, that's even better. So with that, I would like to show you my favorite people, and that is my family. And that's my husband, my 2 kids, and that's my 8-month-old that looks like a snow bunny. So we went to ski this past week, and we had a lot of fun. So anyway, thank you again for having me. Open to questions.
Awesome. Thank you, Dr. Inoa. Thanks to everybody for putting up with all of our technical difficulties. I feel like we're holding this together with duct tape, and probably more effectively 2-inch silk. But so I want to open it back up to Dr. Zachary, Dr. McGuire, and Dr. Kim for any questions you have for our speakers.
Actually, Dr. Jim Mcgarris, I had a question for you. I think sometimes, I guess in general, we get pretty invested in our patients, and when you have particularly like a poor outcome or a family that you've especially connected with, what mechanisms do you have, or in what way have you found that you're able to leave it at the door? Like, what have you done that's been helpful to accomplish that? Because I think sometimes it can be pretty difficult to kind of let it go and be present and be mindful in the moment and kind of be with your family. I think sometimes it can be challenging to kind of just push it back a little bit.
So that's a great question. And, you know, as much advice as I can give you, you will struggle with this for your whole career, because we are human and we are, you know, empathetic and sensitive, and you will take a lot of it at heart. Some coping mechanisms that I found to be very useful is talking things out. And this is where having mentors, having good friends at work, friends you can trust, friends that you are very vulnerable and open with, and discuss either your worst complication for the day, or just a natural progression of the disease and a poor outcome that you couldn't help. I think really it's almost therapy within your field. It really helps, and it really, especially if you talk to a colleague. I'm lucky enough where one of my partners, and probably best friend in the field and outside of the field, is also a neurosurgeon. And every time there's a horrible complication, I want to talk about it. Hey, this is what happened. This is what I think I could have done right, or this is how I could prevent it. But just talking it out with someone, and just hearing that, you know what, of course, it has happened to me, or it's, yeah, I've seen it, or it really helps a lot for you to digest and absorb it. And, the ride home will be different. Your ride home, you'll be, try to process it. Give yourself the time to be sad about it, to be upset about it. And when we go home, we have a rule with my husband. This is, it's an advantage and disadvantage to marry another physician, especially another surgeon. One of the advantages that I find is we talk about parts of the day, and he can talk to me about hand surgery. I have no idea what he is discussing about. It's amazing how we had the same basic training, and we have diverged into completely different careers, where every once in a while I'll ask him, tell me again the difference between stroke and an aneurysm rupture. It's crazy. But we have 5 minutes where he may tell me a part of his day that, didn't go right, and vice versa. And then we just let it go. And it's hard. And in the beginning, you may not be that good at it. But ultimately, and especially once kids, happen and they get older, a little more demanding, and, Violiza, start talking back, wait for that. You'll find that, it gets better. But I think talking it out is very helpful before you go home, so then you don't pile everything inside.
Yeah,
and then I can just add something. So I'm in my early career stage. So a lot of the things that, I carry with me right now as I'm trying to find my way and feel my confidence when things go badly is something that one of my mentors at the Cleveland Clinic told me when I graduated, which is, you're going to feel, there's some days where you're going to doubt yourself. You're going to feel like you should not be doing this, that you really should probably find another career because things have gone badly and you don't understand how. Everybody's been there. And as you are maturing in your career, you will start to feel more and more that I do help more people than these complications show me, even though those are the fresh cases on my mind, because you care. And that's just because you're a good physician and a good surgeon. But you're going to have a lot more people than you heard. So on those tough days, that's something that really sticks with me. And, you know, they should help move us along.
Amanda, I'm going to leave you with one more quote. It's a little funny, but actually sometimes I use it in my mind. My chairman and first mentor in my career, Robert Rosenwasser, always said, whenever there was a bad outcome, sometimes, as you know, patients come and they are brain dead on arrival, and you haven't even had the opportunity to help them. And she'll say, you know, with his Southern Louisiana accent, we ain't treating measles. Not to say anything against pediatricians and the important work they do, and vaccination, obviously, but this is not a benign disease. Cerebrovascular comes with the great highs and the great lows, and the highs are great, but the lows they will really ground you and they will humble you. Every once in a while, you may need that quote just to give yourself that extra oomph that, you know what, it was a tough disease. I did the best I could, and the patient may not have had a good outcome.
Thank you. I had another question, if that's okay. So I'm on my research years right now, and I went to a research meeting and faced an all-male review board. And I think, I'm not fairly assertive person, but I think it can be somewhat hard to get a word in sometimes when you have that situation, unless there's someone that's very cognizant of making sure they assist you or kind of facilitate you having that space to really speak up in. What have you noticed that's been helpful to maintain your voice and kind of be able to kind of hold the audience in that sense when you're in that sort of situation?
Yeah, there has been days, and there are going to be days where you feel like I have so much more to say than this conversation that's turning in circles. Stand your ground. One of the things, you know, that really came out, I think, in the last Women in Neurointerventions dinner at our annual meeting is something that the speaker quoted, which is, if you're not given a chair at the table, bring a beach chair. Give yourself a seat at the table. You deserve to be there. Don't let anybody tell you otherwise. Speak your voice, speak your mind. In a field where women are so few, many of us have had to, you know, like Dr. Inoa was pointing out, just overshoot the excellence bit to get there. You have a lot to contribute. Give yourself that. If you believe in yourself, what you say and the weight that it carries will transpire.
Can I add something? If you can hear me?
Of course. Yeah.
So one thing that might be frightening, but I actually recommend, is that you expose yourself. So if you have something to say, you know, just find that courage and say it, and then you'll see the feedback. So you'll see how people respond. I'm not saying that you should be saying things to get feedback, but you know, when you're confident about something, or when you want to express something and you say it, you know, first of all, like, you truly feel good about yourself, but also with time, you know, as you keep doing it, as you keep exposing yourself, you'll realize that, you know, in fact, well, so you had your opinion, and the feedback might not be as negative as you think, you know, and then the other part of it is that, you know, just because of your gender, people might mention that to you, and they might say, other women, for example, have approached me, and I bet have approached my friends here, and have said, thank you, you know, thank you for speaking up, thank you for, you know, having the courage to say or to participate in the webinar and to do things like that. So, you know, I think as you know, if you do it, I think you'll continue to feel more confident about it.
Mhm.
I'll add one more thing, Amanda. And in my particular department, we have affiliates and we have some females in the affiliates, but within the university, I'm the only female out of all my other male partners. And I found myself early in my career, whether it was sitting through a faculty meeting, case conference, that I was making these internal comments and never really externalizing them out loud for fear of, I don't know, of not really belonging. I'm the only woman here. Do I really need to say that? How will that sound? What will the feedback be? Like Violiza said, you would be surprised unless you say it. So you need to be bold, and you need to just lose self-doubt and just speak your mind. And if for some reason the feedback is not good, which sometimes can happen with any idea you may have, then that's okay. Accept that. It's not because of your gender or your race, or it's just, you know, it's your idea. So just be bold and speak your mind. And I learned that later on.
Fantastic. Thank you all. I appreciate it.
All right. This software is going to cut us off at 6 o'clock, no matter what we do. So I think it may be time to do our little outro. And it's been a wonderful discussion. Dave, any last comments you have?
No, not really. I appreciate you guys all taking the time to help put this thing together. Some phenomenal talks and some phenomenal discussion, both from all three of our speakers, from Dr. Tjoumakaris, Tsai, and Dr. Inoa, and from our three panelists as well. Really appreciate it.
Agree. We'll just get a quick plug for Dr. Rodriguez, who always does a lot of the hard work behind the scenes. Thank you for all your work. Although we didn't have time for the questions, hopefully from the audience, hopefully everyone got a lot of value out of this. Next week, we're going to have another webinar. Although there's a little bit of misspelling there. Applying for post-residency neurosurgery fellowships. We'll have a panel of fellowship directors. Unfortunately, they're all in. I'm so sorry, everyone. But hopefully it'll be useful for people nonetheless. You can see where you can follow both young neurosurgeons as well as Young NIR section, and I actually should have put it on here, WINS as well, women in neurosurgery. And they're all available on social media. As future webinar updates, you follow us on social media as well. There's a companion podcast to the webinar with a lot of similar information, but it'll be a little bit different delivery mechanism and a little bit deeper dive in certain topics. Some are just different. So we do that in combination with the Medical Student Neurosurgery Training Center. Finally, we always like to acknowledge our wonderful representative from the AANS Committee, Priscilla, and we have started a honorary mentor fund in honor for great contributions to our committee and also to the Violiza. And the funding that goes to this honor mentor fund, which is the donation page there, is to help advance medical student mentorship, research education, and participation in organized neurosurgery, particularly students who are otherwise lack access or have difficulty with access. That's pretty cool. Finally, all of these videos, it takes a few days to edit them and get them up, but they are posted on the NREF webinar page. It's easy enough to Google this, NREF Young Neurosurgeons webinar, and you can watch all of these episodes or anyone that's interesting to you. And we usually post when those are posted on our social media as well. With that, I would like to thank all of our panelists for all the wonderful and a lot of use for people, both now and future on YouTube, which seems to have quite the long-lasting effect for people that can find this later. So I appreciate everyone coming, and with that, we'll say good night. Thank you all.
Thanks, everybody.
Thank you. Thank you.
Thank you.
Good night.
Thanks, everyone.
Thank you.